Definition. Know what the definition, know what the parameters are. 90, 95% type 1, 5, 10% type 2. Know that if someone says, oh, I'm having some problems with my blood pressure because I'm taking birth control pills, what type is that? Type 2. I am having blood pressure problems because of the NSAIDs I'm taking. What type is that? If they say, I don't know why I'm hypertensive, what type is that? Type 1. Let's say they say, I don't know why I'm hypertensive, and they're shaped like an apple. Still type 1, because we don't know. Now, I turned that thing off. It turns off when you don't want to, and it turns on when you don't want to. Oh, yes. All right. So, if you're hypertensive, how do we stage it out? Look at the staging. It's actually stage 1 through 4. What I want you to know is stage 1, stage 2. I want you to know what malignant hypertension is. That's stage 4. Malignant hypertension, in your handout that I put up, you'll see a term, sine non qua. I want you to know what that means. Know what the symptomology goes with malignant hypertension, blurry vision, headaches, and all this kind of stuff. That's the hallmark. This is typically something you see in less than 1% of the cases, but it is something that you can actually induce with your intra-arterial, what they call the inadvertent intra-arterial injection of epinephrine. So know what the signs and symptoms are. How do we treat this? What are the medications? Know the different classes, the ACEs, the ARBs, the beta blockers, calcium channel blockers, the, ARB2, the angiotensin 2, and the diuretics. Know the general class. If you know the general class, then the characteristics of the class carry through to all of the meds. Alpha blockers, that was the one I was forgetting. Know about the alpha blockers. Of those, beta blockers, of those, which of those, if you give that, will you likely see hypotension with a reflex tachycardia? Might be something you want to look up, but I'll give you a hint. The alpha blockers. The alpha blockade, that's why we typically don't give those by themselves. We give them in conjunction usually with a beta blocker. And it makes sense when you think it through. Beta blockers. Notable on that. How do they work? What do they do? When do we give it, and why do we maybe back away? This is a class of drugs that does not work uniformly across all races. Calcium channel blockers, on the other hand, are uniform across all races. ACE inhibitors, probably the go-to drug of all nowadays. Used to be beta blockers, but now it's ACEs. So we will see a stepwise progression drug-wise. Lifestyle changes first, followed by maybe a diuretic. That's all they've got, then they're telling you something significant. They're telling you that they do not have a severe form of hypertension. If they can control it with modified lifestyle, exercise, and diuretic. If when that fails though, now we're going to add something to that regimen. So we're going to add probably an ACE inhibitor. That ACE inhibitor, you know what ACE inhibitors are, you know how they work. You know they all end in pril, like captopril, acupril. So it's going to be something that ends with pril. What are we trying to do? We're trying to deal with the neurohumoral component, the renin-angiotensin neurohumoral component that's giving rise to some of that. So if you know the meds, then you start getting a pretty good look-see. Remember, we have covered a tremendous amount of material, and we're only having 50 questions. So don't go dig deep into this, you know? If you do, you're kind of wasting your time at this point. Think about skimming that rock. We're just looking for the high points, right? All right, I think I pointed you in the right direction, all right? So, meds, why do we give what we give? Complications, problems with beta blockers, notable problems with all the antihypertensives. They cause xerostomia as a dentist. You need to know this. ACEs are probably the worst, Now, a patient is telling you they've got, they're taking an ACE and they've got this nagging, dry, non-productive cough. Is that associated with the ACE? I'll leave that to you to look up. How do you change that? Might need to change their medication. Calcium channel blockers. You know that calcium channel blockers have a gingival hyperplastic component, and you see that in about 35% of all CCBs. Heart failure. From hypertension, chronic, poorly treated, or untreated, it gives rise long-term to heart failure. Remember, we said heart failure is probably not a standalone issue. It is always something in response to or some kind of underlying morbidity that has given rise to this condition we call heart failure or congestive failure. So know the definition. If we talk about something that could not meet the demands of the body versus demands of the heart, you should know the distinction between this and this next one. For purposes of this exam, know what the symptomology, signs and symptoms of right-sided versus left-sided are. Real simple. Pooling in the extremities versus other. So pooling in the extremity versus other. Remember that the primary cause of right-sided failure is left-sided failure. What do we call right-sided failure? Cor pulmonale. Medications to treat this, well, it might depend on what it is that we're trying to do. We're looking for causative factors, so correct the underlying causation as much as we can. The signs and symptoms that go with this, we talked in terms of systolic versus diastolic. Just know the definition, you guys. I'm not going to ask you a lot of pointed questions about this. Know the comorbidities that are associated with this. Is this a hyperdynamic or hypermetabolic induced problem, or is it something else? Is it secondary to long-standing hypertension? Is it secondary to a myocardial infarction? Again, know what is the causative factor. Medications, you should know what constitutes appropriate medication choices for the hypertensive. The 1, 2, 3 medication choices, ARBs, ACEs, and diuretics. That's the 1, 2, 3. Why the ARBs and the ACEs? We're trying to deal again with the neurohumoral component. So we're trying to affect that sodium-potassium mismatch. And then we're using the diuretics to pull the fluids. So know the inotropes, chronotropes, diuretics, and then gave you a slide or two on staging. Know what constitutes stable versus unstable. Also want you to know what are considered the appropriate treatment, drug treatment, based on which stage. And that's pretty simple. You think, oh, that's a lot of, no, it's only like 4 or 5 meds. As we get further into the stages, you know, A, B, C, D, as we get higher in the stages, you'll see that our meds will add more, will add more, will add more, until all of a sudden we get no more effect, and at that point, now we've got to look at other things. Progressive, probably will do person in at some point. Remember why I tell you that it is the big time problem from a clinician standpoint. Know what ejection fraction is. Know what ejection fraction is. All right, so atherosclerosis, another contributing factor to heart failure. Atherosclerosis, know by definition, it's progressive. There's no identifiable etiology, and there's no cure. So it is progressive. Pathophysiology, the signs and symptoms. Is it always symptomatic or is it not? When we talk about this, we're talking about stable angina and unstable angina. We're talking about Prinzmetal's angina, and we're talking about syndrome X. Know what the complications of this. What's the ultimate complication from atherosclerosis? What's the ultimate complication? Die. Remember, we said that 40% of patients that have some type of underlying atherosclerotic disease, their first presenting symptom is they're dead. So sudden cardiac death, 40%. The medications, the anti-cholesterol medications and the dilators. When would we do surgery? Why would we do surgery? What is the surgery? We're talking about balloon angioplasty, also known as the PCIs. Know what a CABG is, coronary artery bypass graft? Now, the way I typically ask that question is, which of these conditions requires antibiosis or endocarditis or not? So if you know the condition, you know what it's used for, you'll know what to watch out for. We talked about arrhythmias. Atherosclerosis feeds into heart failure. Hypertension feeds into heart failure. Heart failure, atherosclerosis, hypertension. Then the next in the progression, and think of it as a progression, is you're going to start seeing some mechanical aberrations in the electrical conductivity or activity of the heart, i.e. the EKG. So know by definition what's bradycardia, what is a tachycardia. Know the components of the EKG rhythm. Know what normal looks like. Know what atrial flutter, what AFib looks like. Of these two, which is more problematic? In addition to being diagnosed with AFib, you've got to worry about, they're going to be on the blood thinner. Maybe an antiplatelet drug, but definitely some type of anticoagulant therapy. And that's the problem for you as a clinician. So it might be something as simple as a person's been diagnosed with AFib and they're on a medication regimen. Which of the following would be the expected medications or the classes of medications that they would be on? Remember, atrial, not something that's going to drop you, so they're not fatal. They can give rise to fatal outcomes, but they're not fatal. Ventricular, however, once you know what a PVC is, and once you know what rapid VTAC is, and once you know what VFib is. These are the two that are shockable, the only two that are shockable. You can shock all the rest of these and it won't do anything other than hurt the heart. Know what asystole looks like. Know what asystole looks like. Know what conduction blockade means. First degree, second degree, third degree. Third degree is called complete block. Know what that actually means. First degree, what does that mean? Second degree, two types. All I want you to recognize are terms, so very heavy on terminology here. Conduction blocks, are they tachyarrhythmic or are they bradyarrhythmic? Think. Block means it's a bradycardia. So this is going to be something you're going to have a slowdown. It's going to be a slowdown. And then we talked about ischemic and cardiac myocardial injury. And I've got you a sheet of what the EKG patterns will look like. Let's say that I give you a EKG tracing and it says you're 1 millimeter elevated off the isoelectric line. ST elevation 1 millimeter. What is that indicative of? What is that recognized as a sign of? Or that we have a T-wave inversion. What is that a sign of? These are kind of the universal. What is injury? What does injury look like on EKG? All right, so this is pretty straightforward. If you just recognize your basic rhythms, you know what your bradyarrhythmia, tachyarrhythmia is, you're going to be okay. Guys, I'm having a blank here. What did we talk about with valvulopathies?
Like mitral valve. Mitral valve.
Mitral valve, all right. So do we prophylax for mitral valve?
No.
Okay, so we don't prophylax for mitral valve. Do we prophylax for any of the valvulopathies?
I thought the mechanical one, it's within 6 months.
Okay, it'll be a very specific question so that it'll take out any guesswork on your part, okay? So, specifically though, I want you to know about valve replacement. And remember there are two types here. There's porcine and what's the other one? Mechanical. So actually it's acrylic or it's plastic and titanium, but it's mechanical. All right, favorite question. Which of these require antibiosis? Both. Which of these does the person need to be on anticoagulant therapy? Mechanical. Is that a lifetime, or is that something that they just take for a little while and then they come off? It's lifetime. All right, so you can see antibiosis for both of these, and see a correlation here? You don't have to relearn each and every one of these things. If you learn the basics, you'll find that they do start to overlap. And what we're overlapping here is AFib. What do we say that the person's going to be if they've got AFib? They're going to be on anticoagulant therapy of some sort, right? In addition to this, we talked about pacemakers. And we talked about AICDs. All right, which one of these would be used to treat a, say, sick sinus syndrome, a slow, profound symptomatic bradycardia? Pacemaker. Do we prophylax for that? Not asking in that first 6 months, okay? So again, it's going to be very specific as to what I'm asking. I'm going to take the guesswork out of it for you, right? What about an AICD? When would we use this? Somebody that is having problems where they're having a lot of defibrillation issues, where they have to be shocked continuously, right? Again, do we prophylax for this?
No.
No, we don't. Are these people on blood thinners? I don't know if we mentioned that in class or not. Are they on blood thinners? No. No. Wrong kind of problem that you'd be thinking about there. So, think antibiosis and specifically SBE prophylaxis.
I have a question. Why do you draw a line from the AICD to defib?
Because what would you, if somebody is having fibrillatory runs, right? It doesn't drop them, they just have these and then it goes away.
So would they need anticoagulation therapy?
Not ventricular. Atrial, yes. Ventricular, no. We just need to slow the ventricles down. So they're going to put an AICD in. I was going to tell you something else, but y'all don't need to know that right now. All right.
What is it?
Endocarditis. Know what the definition, what the causative organisms are. Why, as dentists, did we get the reputation as being the identifiable causative factor? What bug is it that we kind of deal with on a regular basis that is counts for about 47%? What is that? And then the one that's less common but more virulent, more problematic, let's say sequelae. What are the sequelae that you see? What's the antibiotic protocol? Penicillin, non-penicillin? What can we do? Local measures like rinses. All right. Okay, seeing how it starts to flow together, guys? My recommendation is get you a piece of poster board. Kid you not, get a piece of poster board, get you a Sharpie. Do exactly what I've done here and start doing a flow chart. Everything in medicine is actually a flow algorithm. No more of this being a cowboy where you get to decide for yourself. No, everything is an algorithm. The way that we manage and that we approach treatment is all algorithmic. This is kind of the down and dirty on the basics of the algorithmic approach. And once you get it all on one piece of poster paper, you can start drawing your lines and you go, oh, well, that's actually not that difficult. It's a lot, yes, but it helps you organize. The person tells you they are allergic to penicillin, but they can take amoxicillin. Is that true or not? Can they take amoxicillin, but they're, quote, allergic to penicillin?
No.
Technically, they can't. But if they're saying they're allergic to penicillin, but they can take amoxicillin, they're not allergic to penicillin, are they? No. Let's say that you cannot give penicillin to this individual. What's our number 2 drug? Clindamycin. What's an alternative to clindamycin?
Azithromycin?
Is the macrolides, the azithromycin, the clarithromycin. Why would we not use a cephalosporin if they're allergic to penicillin?
Because they have a question.
About 18% cross-reactivity. So be careful you don't get tripped up on that. Also know the timing and dosing. You know what the dosing is, right? 2 grams, 600 milligrams, 1 hour before. Dosing is important and timing is critical. All right, today we talk about the start of pulmonary issues. We talk about asthma, COPD, atopic, also known as extrinsic, also known as allergic type of asthma. This is a IgE-mediated response here. The non-atopic, the intrinsic, these are external factors, notably cold, weather changes, stress, exercise, things of this nature. Here's a question for you. I left and I came back in at the end of Dr. Meyer's presentation talking about aspirin and NSAID sensitive asthma. There is a subset of asthma, about 15% of the adult onset asthmatics that have this IgE mediated response. Read your monograph there. It's all arachidonic acid and cyclooxygenase and whatnot. But bottom line is this will trigger and can trigger a severe asthmatic episode. The most severe asthmatic episode is called what? Anaphylaxis. So guys, if you know that asthma is the prototype for all bronchospastic disease. Now you don't have to worry about what's bronchospastic. If you just think bronchospastic, that's asthma. Bronchoconstriction, inflammation, mucus plugging. The 3 components that go with all bronchospastic diseases. Bronchoconstriction, what else? Inflammation, and what's the third one?
Mucus secretion?
Mucus plugging. Now, here's where I caution you, real world versus the textbook stuff. Yes, mucus plugging is a very strong component of all of these conditions. All these are obstructive pulmonary diseases, chronic obstructive pulmonary diseases, but these are considered obstructive pulmonary diseases. With asthma, they can get the air in, they can't, actually, right the opposite. They can't get the air in, so you're going to have, scratch that. They'll get there. It's been a long day, guys. They can get the air in, but they have trouble getting it out. So that's why you'll hear an expiratory wheeze. Expiratory wheeze is going to be the hallmark you're looking for, the expiratory. And you'll see them really kind of squeeze it down. Know what that looks like. Those are the flaring nostrils, the suprasternal retractions, and whatnot. The tripoding, all those physical markers. Large airway, small airway. With COPD, they can get it in okay, they just can't get it out. They get it in, or right the opposite of what I just said. Whatever I just said. It comes in 2 varieties. Chronic bronchitis and emphysema. Now here's just something we didn't touch on, but I'll go ahead and just kind of give this one to you. COPD by and large, comes as a mixed presentation. That's why you can have somebody that has emphysema and they'll have the mucus component, but that's not the dominant form. If it's dominated by mucus, what do we call it? Chronic bronchitis. And those large corpulent individuals, the blue bloaters, again, just memorize that little cartoon. You got it. Hypercarbic drive versus non-hypercarbic drive, you got it. The medications are really kind of what we're looking at here. I got a scenario where you've got an increased AP, barrel-chested individual / pink puffer. All right, 3 to describe the same condition. That's emphysema. Think of it this way. Big barrel-chested Popeye with skinny little legs. That's what Popeye was. You guys remember Popeye? Okay. Chronic bronchitis, that's Bluto. You think they just picked the word Bluto out of the blue? Blue toe, big, you know, blue toe. I just gave you a real. So chronic bronchitis, mucus, emphysema, first flip, all right? Pink puffer. Digress for just a second here. Be cautious. As a general rule, be cautious of redheads just across the board. No offense to anybody. No offense to anybody that's a redhead. But here's the thing. The fact that you, and I'm not talking about a Clairol redhead, I'm talking about that true kind of Irish Celtic background redhead. You know, the white skin and the freckles and whatnot. They've got that coppery